Our knowledge and truth for a healthy living is a must. Here are the experts. Here are the facts. Here is what we testify to and speak. This is We Shop Talk.
Good afternoon, and thanks for joining us on episode 9 of We Shop Talk, presented by South DeKalb Family Physicians. We're here today at the Purple Dot Salon, and we thank very much Dwight Eubanks, who has been our host, a couple of the other previous shows. Today, we're going to be diving into chronic kidney disease. What is the state of affairs? And we have testimonials. The first segment of this episode will be with the experts that we have that will be helping us understand what chronic kidney disease is. And the second segment will have testimonials from individuals who have lived and walked this journey to hear in their own words what the story has been like. We're here today because close to 40 million Americans have chronic kidney disease. That's 1 in 7 Americans. That's 15% of the adult population in America. And for the African American population, it's about 18% of adults, African Americans, who have chronic kidney disease. The scourge of chronic disease has also increased exponentially in years past, and it is now one of the top 10 causes of death in America amongst adults. Why is that so? What can we do about it? This is the reason why we have this very distinguished panel that is joining us today. I'm so excited to introduce to you, all the way to my right, Dr. Emmanuel Minja, who is a transplant surgeon with Piedmont Transplant Institute. He's been with them for close to 10 years here in Atlanta. Started his medical training in Texas, and then his fellowship up in Minnesota and also in Boston. We're so pleased that you're joining us today, Dr. Minja, to give us some insights and expertise into your field, what you do. And next to Dr. Minja, we have Dr. Evelyn Lewis, who's also been here in Atlanta for well close to 20 years. As a practicing nephrologist, is one of the partners at the Southwest Atlanta Nephrology, a nephrology group that has about 6 nephrologists here in the state, in the city, that focus exclusively talking about treatment of chronic kidney disease and hypertension. He went to medical school in Tuskegee and did his fellowship. Kentucky, but undergrad was Tuskegee, and med school was in Kentucky. And then, of course, his fellowship, which was through an NIH grant, and he's here with us. Dr. Evelyn Lewis, thank you so much for joining us today.
Thank you. Thanks for having me.
And to my left is Dr. Leo Vaje, who is one of the managing partners too with Caritas Medical Center. He's also the director of the Caritas Medical Research, LLC. He did his medical training in medical school and out of New York, and then I think fellowship was at the University of South Florida. That's where I actually met Dr. Vaje many years ago. And it focuses a lot on chronic kidney disease and hypertension as a practicing nephrologist. Dr. Vaje, thank you so much for joining us.
Thank you very much for having me.
Thank you. So I think the first question really will be, Dr. Vaje, we'll start with you. What exactly is the kidney? We know the kidney is a bean-shaped organ that is probably the size of your fist for those of our viewers that are watching, and we all have 2 in our bodies. Dr. Vaje, what is the function of the kidney?
So the kidney has many functions. We have 2 kidneys right in our backs, right? And I joke that I am very happy to take care of this organ because we have 2. So when one fails, you have a backup. You know, my brother gave my sister a kidney. He has 1 kidney and he's still doing well. But each kidney has about 1 million nephrons. The nephron is just a unit of the kidney. In each nephron, we have the filtration of the waste products and what will eventually become urine. And everything now gathers into what we call the renal pelvis and eventually passes the urine out. So each one of those nephrons functions individually and does this whole filtration that eventually will get urine. So we removing natural waste products, excess water, and then it balances the minerals in the body. The fluids in the body, the minerals just have to be at the right level all the time for the body to function well. Now, what a lot of people are also not aware of, the kidneys are also very important for other things. So to maintain your blood count, to prevent anemia, the kidney makes a hormone that makes your bone marrow make blood cells. Also, the kidneys are responsible, produce hormones that help maintain your bone function and also control blood pressure. So I joke a lot, when I talk to my referring primary care doctors. I say, well, I don't know why you're sending your hypertension patients to the cardiologist. The kidneys control the blood pressure. You should be sending them to us, and we kind of laugh about it, So, but we all work together. So, yeah. But basically, those are the functions of the kidney.
Thank you so much, Dr. Vajay. In other words, the kidney is a filter that filters toxins from the body, waste products. And just like Dr. Vajay has alluded to, there's actually other levels of functions that the kidney have. So if your blood count is low and you have kidney disease, it could be because of the kidney. Or folks that may have gout may also have some kidney manifestations from that. Or the electrolytes and the fluid balance in the body, how much you pee. And so to you, Dr. Lewis, can you help us understand what acute kidney disease is versus chronic kidney disease? Today, we're focusing on chronic kidney disease, meaning this is something that is progressive and that is going to be there for many years. What is the difference, just as we're starting this conversation, the difference between an acute kidney injury or kidney disease versus chronic?
So thank you, Dr. Akintobi. So with acute kidney injury, basically the difference between the two is the duration of the insult. So if you could imagine somebody with acute kidney injury, you have normal kidney function, and because of some type of insult, it could be medication, it could be an infection, you experience an acute drop in the kidney function. And over time, that insult is removed. That type of injury, the kidneys can, for the most part, can recover from. You can regenerate function from that. So acute injury, normal kidney function, some insult, over a couple of weeks, function returns to normal. With chronic kidney disease, there is a decline in kidney function, but it persists longer than 3 months. So by definition, any reduction in kidney function that persists for longer than 3 months is considered, CKD. And not only can it be a decline in the kidney function, also some urinary abnormalities. So you can have normal kidney function, you could have protein in your urine or blood in your urine that persists for more than 3 months. That, by definition, is considered chronic kidney disease or CKD. You can also have some structural issues with the kidneys, obstruction or some type of mass or something that's impairing the function of the kidney that persists for more than 3 months. By definition, that's considered CKD. So the difference between acute and CKD, acute kidney injury and chronic kidney disease, is just the duration of the insult.
Thank you so much. And again, for our audience, Dr. Lewis is saying that with acute kidney disease, there is a chance that you can bounce back. With chronic kidney disease, it can be progressive and it can last for a longer period of time. Let's turn over to the surgeon on the panel today. And I know by the time the patients get to you, it's probably far gone. But what are the signs of chronic kidney disease, Dr. Minja? Knowing, of course, that 90% of individuals that have kidney disease are clueless about it. So what are those signs that you can advise that our patients look out for those 10% that have some symptoms? I know we're going to talk about your day-to-day with kidney transplant.
Yeah, so when you think about the symptoms of chronic kidney disease, we have to go back to Dr. Vajay was talking about what's the function of the actual kidney itself to understand what symptoms it can have. So one of the most important things that the kidney does, it filters the blood. It filters the blood so it gets rid of all the excess impurities. So the excess water that we don't need, it filters that out, then you get to pee it out. It filters all the electrolytes that you don't need, then you get to pee all these things out. In terms of function of the kidney, in terms of making the hormones to allow our bodies to make red blood cells so that you're not anemic, all those things come to effect. So you can start thinking about if your body doesn't really filter a lot of fluid, majority of the time that fluid now starts seeping into your tissues. So people start seeing, hey, I got my legs are a little bit more swollen than normal. Maybe my hands, I'm gaining all this weight that I really don't understand what that's from. Those are some of, like, the mild symptoms that people see. Sometimes that fluid buildup, because the body is not really filtering and getting rid of it, slowly it can start going into the lung space. So people can start feeling, I just can't breathe normally. And that's just because some of that water that should have otherwise been peed out and filtered out now starts seeping into the lung spaces, so you're not able to feel well. As one of the common things that people experience is just fatigue and just loss of energy and interest. And a lot of that comes into account when the body is not able to make enough red blood cells. So some people start getting this chronic anemia where their level of energy just drops over time. And all the impurities that the kidney is supposed to be filtering, sometimes that just stays in the blood. And that can be the cause of this fatigue. Sometimes people get this insomnia, inability to sleep. And it's just, it's just because things are not, they're not well balanced in the body, and that's how you develop all these things. Those people who have high blood pressure, it becomes a little bit even harder to control the blood pressure because, you can imagine blood pressure is a measurement of how much volume you have in your blood vessels. So if this volume is not being taken up, and peed out, so you can imagine that volume just kind of stays in your blood vessels. And when you measure the blood pressure, it's just getting higher and higher and higher. So, you can have any symptoms from just lack of energy, not being able to sleep well, not being able to breathe, just gain in weight for unknown reasons. Swelling is one of the very, very, common things for just unknown reason. Like, hey, over the last, 2-3 weeks, a month or so, I just been, I'm watching my legs, and, when I press on my legs, it's just like all this, dimpling, so to speak, from all the extra fluid. So.
Thank you so much, Dr. Menja. And just to follow through on what Dr. Menja has also said, some folks may also have puffiness of their face. Their face just seems a little more swollen because of that fluid retention. Some may have some dry skin. Some may have some darker skin. And so, again, the kidney, as just all our three specialists have mentioned, has a ton of body function. And so when you start to see some of those symptoms, or for some other people, it may be that they start to notice some foaming of their urine, because there's a lot of protein that comes out in the urine. So you pee into the commode, and you can see that the urine either is changing color because there's blood in the urine, or because there might be some protein in the urine, which are heavy molecules that we're going to talk about that can make the urine also seem like it's foamy. So if you have a foamy urine that is new, definitely a reason to go talk to your doctor. But to you, Dr. Vijay, let's come back to you. So how do you categorize chronic kidney disease? So, and how do you know, for individuals that might be interested in know what their numbers are, what are those numbers, just like checking their blood pressure, that they need to know about?
Thank you very much for that question. So I just want to piggyback on what you all discussed earlier regarding the symptoms. Like Dr. Menja said, most people don't actually have symptoms. So, I don't want people going thinking, okay, when I have these symptoms, I need to, right? So 90%, I think one of you said, 90% of people do not have symptoms. So it's not good to wait for symptoms. Most of the clients that Dr. Lewis and I see come to see us not because they have symptoms, but because their blood test was abnormal. So that really emphasizes what he was saying. What test do I need to do to know, if I need to see someone? Because if you wait for symptoms, it's too late for kidney disease. So now, going back to symptoms. So there's something we say ABCs, right? For general medicine, know your ABCs. Know your A1C for your diabetes, know your blood pressure, and know your cholesterol. Well, for kidney disease, it's a little more complex. We don't have simple letters like that. So two things that need to be done for you to know where you are. One is the blood test, for you to know the eGFR, that's the estimated glomerular filtration rate. Well, it's a long word, right? So eGFR, they say it's easier, but it's not like ABC, right? But the kidney is a complex organ, so everything related to the kidney has to be complex. So your eGFR is a measure of how well your kidneys are cleaning the blood. So if we say, I try to make it easy for my clients to see. I just say between 0 to 100, even though it can be up to 120. So between 90 and 120 is what we'll call stage 1. Right? I wish we had a little chart here to be able to go through that. So between 60 to 59 will be stage 2. Now stage 3 is between 30 to 59, but it's divided into two, 3A and 3B, because there's, the way we take care of them because of how quickly those in 3B progress compared to 3A, it's been subdivided. So 3A is between 45 to 59, and 3B is 30 to 44. And then stage 4 is between 15 and 30, and stage 5 is kidney failure, that's below 15. But now, in addition to the eGFR, which is a measure of how well your kidneys are cleaning blood of the waste products, right? It's calculated using your creatinine, which is a measure of how much, is a breakdown product of the muscles, your creatinine. Your creatinine, your age, your sex, and sometimes we use some more complicated equations, but the easiest one uses those 3 to calculate it. Most of the test results you get now show those numbers, the eGFR, so you don't have to worry about calculating that. But now the other piece is the UACR. That's how much albumin or protein in the urine. Because I always tell my clients, sometimes they feel, oh, my kidney function is still normal. But I tell them, no, I'm very worried about you. Say, why? But I'm still at stage 2, right? I'm more worried about my client with stage 2 with the 10,000 milligrams of protein than a guy with stage 3B who has no protein. And they're like, why? I tell them, because the one with a lot of protein is probably going to progress faster than the guy who has been staged. I've seen people with 3B for a long time with no protein. They keep their blood pressure well controlled and do all the things they need to do, and they don't progress. But if we don't get that protein down, because it's a sign of a lot of inflammation, normally the kidneys do not allow, remember what we said earlier about the nephron? So the glomerulus is the first part of that nephron. The blood is on this side. What will eventually become urine is on the other side. So usually those junctions are real tight. It does not allow much protein to pass through. When you start having inflammation, the protein starts to pass through. So the more protein you have, the more inflammation you have. So we now use that amount of protein to, so there's a heat map. Yeah, we really should have brought a heat map here. So we'll see if they can add it before this is posted. So, but anyway, someone who is at stage 2 with no protein is very different, depending on how much protein they have. If it's 2A, and then depending on how much protein, so we have 3 categories of the protein for each stage. And the more your protein, the more likely you are to progress. So, but looking at the heat map really makes it vary, because someone who is 3B with a lot of protein is on the same level as someone who is stage 4 with no protein.
Thank you so much, Dr. Vijay. And so what Dr. Vijay has just said very clearly is when you go in and get a blood test with your primary care doctor or any of the specialists, and they do that blood test, they do your blood count, and they can also do what is called your blood, your chemistry. When they do that chemistry, one of the tests that you will see reported on your blood test is called the GFR. The GFR is what Dr. Vijay has described. If your number is 90 and over, you have stage 1 kidney disease. A lot of people are in that category and they don't know it. If your number is between 60 to 90 of that GFR, you have stage 2. If your number is between 30 to 59, you have stage 3. If the number is between 15 to 29, is stage 4. That number, if it's less than 15, you have stage 5, which is end-stage kidney disease. And that's when we're talking about additional treatments like dialysis and other things that need to be done. What Dr. Vijay has also described is the fact that the kidney is like a sieve. So imagine you have a glass of milk with Cheerios that you pour through a strainer. The milk we go through. The Cheerios is the protein. The Cheerios should not go through. When you start seeing Cheerios go through the sieve, it means there are holes in the sieve that is too big. That is a function telling us when you start to see foamy urine with protein that Dr. Vaji was alluding to, that there is more advanced kidney disease. So protein in the urine, when you go in and your doctor checks your protein, they dip your protein in the urine, they can tell, or they tell you to do a 24-hour urine test. It can quantify how much protein you have. Dr. Lewis, so what are the causes of, now we know what the kidney functions are. We now know that there is chronic kidney disease versus acute kidney disease. We also now know the staging of kidney disease. What really causes chronic kidney disease? Why do we have 40 million Americans with this condition today?
Thank you. In the United States, and I think the data supports worldwide also, you can extrapolate that to worldwide. The two leading causes of chronic kidney disease are diabetes and hypertension. Okay? If you look at the prevalent population of patients on dialysis in the United States, or even on the CKD patients, diabetes and hypertension. Then you have a smattering of other things like what we call glomerulonephritis. That's type of an inflammatory process that kind of can happen in the kidneys. We have some other autoimmune things or some genetic conditions that can contribute to chronic kidney disease, but hypertension and diabetes are the big two.
Thank you so much. So about 30 to 40%, diabetes is number one. 30 to 40% of folks who have kidney disease is diabetes, followed by high blood pressure, like Dr. Evelyn Lewis has mentioned. But along those lines too, for men who might have an enlarged prostate with obstruction over time that is not attended to, that can build up pressure in the kidneys and cause kidney disease. Individuals that have autoimmune conditions like lupus, nephritis, they too can also have kidney disease as a complication. Folks that have recurrent infections in their kidney that keep having UTIs that just will not resolve, they too can also be at risk for having chronic kidney disease. But the bottom line is that if we treat high blood pressure well and we prevent diabetes, we may prevent 70% of chronic kidney disease in America. It's just a fact that if we can treat blood pressure right and diabetes is well under control with that A1C down to below 7, the likelihood that one will have complications that can result in chronic kidney disease is less. The additional things that we know, of course, and I know you can comment on this a little bit more, is the use of certain medications, like medications like ibuprofen, like Celebrex, like Advil. People that use those chronic medications for a long period of time, it can also damage the kidney. Why is that so?
So it's just, so we live in the South, and folks love their goody powder and stand back, and so those NSAIDs, just based on their mechanism of action, can exert an adverse effect on the kidney. And sometimes over years and years, that damage is irreversible. Acutely, sometimes we can see those type of medication causing an inflammatory process in the kidneys, like an inflammation, like an allergic type reaction, if you will, and just withdrawing them, you can see some improvement in the kidney function. But a lot of times what we see are folks who take those things, a couple of 100 milligrams of ibuprofen daily for myriad of reasons, some legitimate, but you have to be very, very cautious when you do that. And if you're having that much pain that you need that many medication or taking that much NSAIDs, you really want to get that pain checked out to see exactly what's going on.
Thank you, Dr. Lewis. And so, rather than use ibuprofen or Advil or Motrin, you can use Tylenol because they work in different ways in terms of how they affect the kidney. But there is no question, kidney doctors hate those medications we call the non-steroidal anti-inflammatories. When I send somebody to go see them, that's the first thing they're looking for. What medications? What is the list of medications? If you see any NSAID, and it's a long list, ibuprofen, Advil, Aleve, Celebrex, goody powder, all of these fall into that category. They affect the way prostaglandins are made in the body and ultimately will damage the kidney. Not just for use for one day because I have a sore ankle or because I have arthritis, but people that have chronic pain, like arthritis, should not be on this medication long term because it will ultimately damage the kidney. There is no question about it. And so it's very important that as you drink enough water every day, which we're recommending 64 ounces of water to help to flush the kidneys, You also have to be aware of what you're putting in your body as medications. Or if you're taking other medications like the ones called diuretics, that you have to be careful that those medications are being monitored well by your doctors. Thank you so much, Dr. Lewis and Dr. Vajay. Let's go to our surgeon. We know now in America, 750,000 of the 37 million or so 40 million have end-stage kidney disease, meaning they have stage 5, meaning that their kidney function is below 15. Of those, we know that 550,000 are on dialysis. And then we know that 250,000 are transplant patients. We also know, if we're going to put a dollar amount to it, that for everyone that has chronic disease in America, the cost per year for healthcare is $38,000. $38,000. If you don't have kidney disease, it's $5,000. Big difference. So you look at the end of the day, if you have stage 5 kidney disease and you're on dialysis, the cost to the healthcare system is $50 billion every year. For others that don't have chronic kidney disease, that have other kidney disease but not stage 5, $80 billion. This is almost a $200 billion industry that we're talking about in terms of healthcare and how we can help to prevent that from happening. But to you, Dr. Manger, as we look to treating end stage, and we're going to talk about other things, I want us to focus a little bit because that's your area. In terms of end stage kidney disease, we know we're talking about dialysis or transplant. How has that evolved over the years in terms of how patients approach when you have stage 5 kidney disease, what your options are?
Yeah. So again, the two main treatments, when your kidneys are not failing, you have to have a treatment system that works as a kidney. Dialysis is one of those treatments where, and what is dialysis, right? You can imagine the kidney is not working, you have all these impurities that are in your blood and you have to clean them out, right? So dialysis is a machine that actually filters these impurities. And you have two forms of dialysis. The most common form of dialysis is hemodialysis, meaning that a machine that's hooked up to the bloodstream and it actually filters. It takes the blood, filters it as if it was the kidney itself and returns back into the blood vessels. So majority of the people who go through treatments, they go through this. But there's also another type of dialysis is called peritoneal dialysis, which means that you can allow a catheter to infuse, to put in fluid into the abdominal space, and that fluid being in there, it just allows all those impurities to filter out, and then again, the same way that fluid was put in, at the end of X amount of hours. Most of the time, these people do that overnight, where you just go at night, people are hooked up to a machine, it does it while the person is sleeping, you wake up, and then you filter out all the impurities. So those are the two main ways at which you can treat end-stage kidney disease. And, in terms of medical treatment, the ultimate treatment is to actually provide an organ that now works the same way. And when we talk about transplantation, that's exactly what we mean. We mean that we find a kidney from another person that gets placed into the person with end-stage kidney disease, and now once that kidney is in that person, it acts as a new filter for that person. So it replaces the need for dialysis, and that person gets to regain their kidney function. There's several types, of transplantation that we can think about in terms of options. So by far, the way that we get kidneys are from deceased donors, and there's another way that we can get a kidney from a living donor. And I think it's important to understand what does that actually mean. So a living donor, it means that anybody who is healthy. It can be a relative. It doesn't have to be a relative. It can be a complete stranger. It can be anybody with healthy kidney function, with 2 kidneys, can donate a kidney to anybody. And that's, in simplicity, what a living donor is. And that person gets evaluated by transplant centers to make sure that, once a transplant center declares somebody is able to donate a kidney, those people normally have gone through a lot of testing to make sure that we can predict with the best ability that once that kidney is removed, the remaining kidney will continue to work just as normal, and making sure that not only that person continues to live just a normal life, nothing changes in that donor in terms of what they do, how they live. It does not change anything. So once you donate a kidney, it means that your life, once you recover from surgery, you're expected to just go back to exactly what you were doing just before you donate a kidney. And I'm bringing that up because a lot of people, sometimes they hesitate because, again, you don't have enough information or misinformation about what does it mean to actually be a donor and what are the possible repercussions of donating a kidney. Some people think that, hey, once I donate a kidney, my life is going to change for the worse. So why should I actually do that? But there's a lot of work that goes into that. I can testify that I'm in contact with a lot of living donors who actually go out and do absolutely amazing things. Last year, I had the opportunity, I'm just going to put this plug there, to join a team of living donors who are just there to raise awareness in terms of what does it mean and what can you do after you have actually donated a kidney. Every year they do a lot of these events, but one of those events was to go climb Mount Kilimanjaro. So
let's put that in perspective. Dr. Minja, you just can't gloss over that. Let's put that in perspective. Yes. We're not talking of Stone Mountain. This is the highest peak in the continent of Africa.
19,200 feet above sea level. So
how many days?
That we did a 7-day trek.
7 days, ladies and gentlemen.
And again, these are the things that not only that, this group is called Kidney Donor Athletes, KDA, but it's not specifically a group of people that, hey, these are super athletes that they can do these things. These are normal people who just saw the need and said, you know what? There is somebody out there who needs help. Take my kidney, give it to them. And they're behind the scenes showing this on a daily basis. I've seen these people run marathons. I've seen these people do all kinds of crazy bike tricks. But all this is just to show that you can donate a kidney and live a completely normal lifestyle after that. And why is that important to address just from the aspect of living donation? At any point in time, there is over 100,000 people who are actually listed for kidney transplantation, for need for an organ. 90% of those need a kidney, right? When you look at the data on how many kidneys that we do every year, we do close between 20 and 30,000 kidney transplants every year. And that's a combination of deceased donors and living donors. So every single person who is an organ donor, we say it's 8 lives changed, but it's 8 lives changed at many generation levels.
And thank you so much, Dr. Minja, for just being very thorough, because this is an extremely sensitive topic that I think oftentimes has a lot of misinformation. But the patients that Dr. Minja was referencing now are the ones that have stage 5 kidney disease. So I still want a nephrologist, Dr. Vijay and Dr. Lewis, to comment on the stage 1 to stage 4 in terms of the treatment. But before then, Dr. Vijay, what is the role of genetics in chronic kidney disease? We know there is a lot of conversation now about the ApoL1 and the fact that for African Americans, there are about 13% that have that, the variant of the gene, and that can increase the likelihood of having kidney disease up to 3-folds to 5-folds. I wanted to comment, and then we're going to talk very quickly about peritoneal and hemodialysis before we end this segment. What is the role of genetics? What is the state of the science with the role of genetics, and is this something you're recommending that we do routinely for people of color?
Yes, thank you very much for that question. So a lot of people, clients we classified as having hypertension as the cause of kidney disease. With technology and science progressing, we are realizing that some of them, that's not just it. So, when we do biopsies, like people who have diabetes, and we just classify them that the cause of their kidney failure was diabetes, sometimes half of them, diabetes is not the cause of their kidney failure. So genetics is a field, like within the last 20 years, has really advanced a lot. And in my practice, we tried implementing it a few years ago, and we had challenges with the insurance companies covering, and our clients got upset because insurance wasn't paying. Well, we started doing it again just last year because now the coverage is better, and we are able to get panels that some of those conditions we actually have treatments for them. Now, the ApoL1 you allude to for African Americans, but actually the New England Journal of Medicine, there was also a study showing in West Africa, and actually Nigeria was one of the places where a lot of the people who were tested, it's also very prevalent there, and it's the same association with kidney disease. So, so some of my clients, of course, they're concerned, well, if you find I have that ApoL1, you don't have a treatment for me. And that's true, we don't have a treatment yet. But there are studies going on now. In fact, I can't say, I'm very excited to be alive today as a nephrologist. With the things that have become available the last 5 to 10 years, I think Dr. Lewis shares the same thing. Before now, our clients, all we could tell you was, a client with stage 1 through 4 kidney disease, like you mentioned, we could tell you was your diet, exercise, and we could give you ACE inhibitors and angiotensin receptor blockers, and that's about it. But the last few years, we now have, many more medicines coming up. But now we also now know about the genetics. And so it's not just, prepare you for dialysis. Because in fact, I used to go see primary doctors then and refer to ask them to send me the patients to get involved in the care with them. We're not taking over, we co-manage with them. And once someone showed me, well, the American family physicians, the recommendation to refer was at stage 4. Well, if you send me a client at stage 4, all I can do is get them ready for kidney dialysis or transplant, right? Well, at that time, maybe that could have made a little sense because all I could do was give them ACE inhibitors, diet and all, but I still didn't agree with that because I do know a lot of clients I see, when I go back to see their primary doctor, say, what did you do? I've been trying to get them to get their blood sugar controlled for years, and they were not listening, and they came to see you. I said, well, I have a chart in my office, the heat map I was talking about, right? Everyone who comes in, I tell you, okay, this is where you are, this is dialysis, this is... So they go back, I won't tell you it's 100%, but a good number of them go back, and they are more engaged with their primary care provider in trying to make sure they, get their sugar controlled, get their blood pressure controlled, all the things you mentioned earlier. So that helps to slow the progression. So we now, with the more medicines we have, we're really encouraging early referrals. We are co-managing, we're not taking over the management, but together we can help our clients to delay progression to kidney failure because like Dr. Minja just said, those numbers are going up every year, and it's like the burden on the clients, for me as a clinician, that's the most important thing. But for the public policy people, the burden on the system, the economics, it's just, healthcare is now 25% of GDP. They can't continue, right? So we really need to go upstream to try to slow this, and that's why when you called me to do this forum, I kept everyone waiting. I was saying this, but I just couldn't miss it. Any opportunity I have to be involved in trying to educate the public, because 90% of people with chronic kidney disease do not know it. So he said almost 40 million, 37 million people have chronic kidney disease. 90% of them do not know it. That's a big problem. So people need to get tested and know. 40% of those with stage 4 and stage 5 do not know it. 40%. So they may be needing dialysis or transplant very soon, and they don't know it. So you have to get tested to know where you are. So it's really very important. So, but thank you so much for...
Thank you so much, Dr. Vijay. And the other piece too, just in terms of being the head of a medical research center, the Caritas Medical Research LLC, we know that African Americans make up about 13% to 15% of the American population. But when you look at the way we enroll in clinical trials that help to discover new medications, and we know that medications that work in a certain way in white Americans may not work in the same way in Asian Americans or work in the same way with black Americans. It's a known fact. We have to encourage African Americans also to be part of more clinical trials. So we make up only 7% of clinical trials in America. We make up 15% of the population, but in terms of enrollment in clinical trials, it's only 70%. It's an exciting time, just generally in medicine, because of all the new developments that we're seeing, particularly with new generation medications. For many, many years, it was either the ACE inhibitors or the angiotensin receptor blockers, the ARBs, but it's a myriad of medications now that we have, which is good, knowing that, again, we want that referral to be early to the nephrologist, to the kidney specialist, not at stage 4, stage 5. Can they go see the kidney specialist at stage 2, stage 3? Can we start to have those conversations? And just when we see the number at 59, we're not saying, well, we can still watch this for another year, even as primary care physicians, that will get people going very quickly.
Now that you heard the facts, apply the knowledge. Contact your doctor or healthcare specialist. Scan the QR code to provide more information on today's talk. See you on the next We Shop Talk.